basically discuss ACS and acute MI and how we got to the current guidelines. And as Rajesh said, I actually chair the Canadian guidelines. Believe it or not, we have separate Canadian guidelines. And then there are the US guidelines and the European guidelines. But I'm going to focus mainly on the US guidelines and the European guidelines and the choice of antiplatelet therapy and the evidence behind the various antiplatelet options. If we go back almost 20 years now, CURE was published in 2001, and in 2021, next year, will be, in March of next year, will be the 20th anniversary, really, of CURE, which was really the first P2Y12 inhibitor, other than ticlopidine, perhaps, but really the first P2Y12 inhibitor to show a benefit in patients with acute coronary syndromes. It's a trial that kind of was run under the radar, but really in some ways started a new era into the use of P2Y12 inhibitors in patients with ACS. And then the exaggerated effect, the larger, if you will, effect in the PCI patient population. And it's an early effect, and then the curves continue to diverge for about a year. So that was really the starting point. Again, 20 years ago, and we've come a long way since that time. One of the things about this particular trial was actually the dose of clopidogrel that was used. It was basically a guess. Nobody really knew the right dose at that time to use. There was some data from a trial called Capri that suggested 75 milligrams a day was adequate with a 300 milligram loading dose, but nobody really knew that that was the right dose. So the question, of course, was what if we used a more intense dose? Would that work? And that was really the subject of the current OASIS 7 trial, really a massive study, 25,000 patients treated with the higher dose of clopidogrel, the double dose of 600 milligrams, followed by 150 milligrams a day. And the overall results are shown on this slide. No significant benefit on the primary outcome of the double dose of clopidogrel versus the standard dose of clopidogrel. You'll see the hazard ratio is 0.94. It's not significant. So, was the double dose of clopidogrel doing anything? It probably was, because it increased major bleeding. You'll see on the right-hand side. But in the overall population of patients, there was no benefit of doing that. We did look at the subgroup. It was a big subgroup, 17,000 patients of those who underwent PCI. And there, like in most ACS trials, we see exaggerated benefits of P2Y12 inhibitors. Here, we did eke out a 14% relative risk reduction, and there was a reduction in stem thrombosis with the higher dose of clopidogrel. Well, we have newer drugs as well that have more efficient metabolism, and that give you a more potent effect. One of those drugs is Ticagrelor, which is also a thienopyridine P2Y12 inhibitor and was evaluated in the Triton study. And here it went head-to-head against clopidogrel, 300 milligram versus 75 milligrams a day, and a clear benefit over clopidogrel in that trial. Overall, there was about a 20% relative risk reduction favoring Ticagrelor. And you'll see most of the benefit was early, but then also over the long term, there was some additional separation of the curves. But really the biggest effect happened early in this trial. And the second thing about the study is that the main benefit in the study was on non-fatal MI. There was no significant difference in cardiovascular mortality between the groups. Now, of course, as we intensify antiplatelet therapy, we're going to see more bleeding. And in this trial, there was more bleeding, and you'll see it was published in 2007. And remember, it wasn't really until maybe, 6, 7, 8 years ago that we started really understanding the importance of bleeding as a side effect. So we kind of just accept all of these bleeding complications as a trade-off for the better efficacy. But here, clearly more bleeding compared with clopidogrel. Remember, clopidogrel itself has more bleeding compared with placebo. And this included major bleeding as well as life-threatening bleeding. And what about Ticagrelor in the conservatively managed, non-stented patient population? That was tested in another huge trial called the Trilogy study, really a massive effort where patients who were not originally scheduled for intervention were randomized to either prasugrel or clopidogrel 75 milligrams a day. And there did not appear to be a benefit of prasugrel in the overall patient population. You may start to see over the long term some separation of the curves, but overall, no significant benefit. So prasugrel is really a drug that we use and we target to patients who are undergoing PCI and who are at low bleeding risk. Well, then there's Ticagrelor, and Ticagrelor was evaluated in really a landmark trial now called PLATO, broad population of patients similar to cure, so it was an invasive patient population and a conservative patient population, conservatively managed population, and they initiated the drug early in the emergency room prior to the intervention. And really the rationale was based on this excellent study that was done by Paul Gerbel, which showed that when you give Ticagrelor, you get a very rapid antiplatelet effect. And well, let me put it this way, it's more rapid than clopidogrel. Can you get even more rapid? Sure you can with an intravenous agent, but it's a pretty sharp increase in inhibition of platelet aggregation that you get with Ticagrelor, and far more than what you would see with clopidogrel. And because Ticagrelor is not a thienopyridine, it's a P2Y12 inhibitor, it has a faster offset than clopidogrel. Now, what does that mean? Essentially, what that means is when you discontinue Ticagrelor, the slope for the reduction in the effect on platelet aggregation is much steeper than an irreversible drug like clopidogrel. So you'll see the slope of this dark blue line is much steeper than the slope of the clopidogrel line in light blue. That's what we mean by offset. When we talk about offset, we're talking about it's a rate that we're talking about. And the two lines intersect at about 48 hours. Remember, you're starting off with a much higher level with Ticagrelor when you stop it. So at about 48 hours, between 24 and 48 hours, they intersect, and then Ticagrelor drops off from there. So the pharmacology of Ticagrelor, I think, is important to understand if you're going to use it in routine clinical practice. And you'll see the key trial here, the PLATO trial versus clopidogrel, with a clear reduction favoring Ticagrelor. Overall, 16% relative risk reduction, and it was highly statistically significant. The interesting thing about these curves, again, they look a lot like the curves from the CURE trial versus clopidogrel, where you see some benefit early, but continued divergence of the curves, continued divergence all the way out until 1 year. And there was a price to pay, of course, for the more intensive antiplatelet therapy, and that price to pay was more bleeding. Now, overall in the trial, there was no significant increase in bleeding. But if you categorize bleeding as to non-CABG, PLATO major bleeding or TIMI major bleeding versus CABG related, there were the expected increase in bleeding that you might expect to see with a more intensive antiplatelet drug. But I think here is really what made the biggest difference and had the biggest impact on the guideline recommendation, was that not only was there a reduction in the non-fatal outcome of myocardial infarction, but there was also a reduction in cardiovascular mortality. And this was really the first time that we had seen an antiplatelet drug reduce cardiovascular mortality. And really quite convincingly, it's only one trial and it wasn't the primary endpoint, but really quite a convincing reduction, at least for me, in cardiovascular mortality. The hazard ratio here is about 0.79, p-value is 0.001, upper limit of the confidence interval is 0.91. What this translates to in the PLATO trial is really a difference in about 100 deaths. You know, we're talking about COVID deaths right now. Just within the context of this trial, there were 100 people that were alive at the end of the day, 100 more people alive at the end of the day in the Ticagrelor group versus the clopidogrel group. And I think this is really what has influenced practice in many regions of the world. Some other nuances of the trial that I think are important to understand is that there was consistent benefit in the invasive managed population, but also in the medically managed population. We don't see these patients as often, perhaps, anymore, because most people will receive at least a coronary angiogram. They may not get a stent, but most patients will have a coronary angiogram in 2020. But still, if there is no stent implanted, there is a significant benefit as well for Ticagrelor. And then what about versus the higher dose of Clopidogrel? Can you get away with just using a higher dose of Clopidogrel like I showed you? Well, in this trial, they allowed for a 300 milligram loading dose of Clopidogrel and a 600 milligram loading dose of Clopidogrel. And you'll see the hazard ratios here are absolutely identical, suggesting a benefit versus the lower dose of Clopidogrel and the higher dose of Clopidogrel. And again, this has impacted guidelines globally. So what are the guidelines? What do they actually say? Well, I think I don't know where the AHA-ACC guidelines are right now for ACS. I think they're due for an update. But the guidelines were clear that a P2Y12 inhibitor, in addition to aspirin, should be administered for up to 12 months. These are the non-STEMI guidelines in patients without contraindications. And they recommended either Clopidogrel or Ticagrelor, but they also had a sentence, and this is a big deal for the American guidelines, that it is reasonable to use Ticagrelor in preference to Clopidogrel for P2Y12 treatment in patients with non-ST elevation ACS who undergo an early invasive or ischemia-guided strategy. And the European guidelines, I think, the thing I like about these guidelines is that they're so blunt and clear. There's not a lot of additional language that you don't need. Basically, they say Ticagrelor is recommended for all patients at moderate to high risk of ischemic events, regardless of initial treatment strategy, and including those pre-treated with Clopidogrel. So that's really how we got to the current guideline recommendations. And then we have a whole, a lot of evidence now about duration of therapy and individual selection of these agents. And I think that's going to be the subject of my colleagues' presentations as they follow. So thank you very much.
Thank you, Dr. Mehta, for that excellent presentation. So I'm going to open it up for a discussion from the panel members if anyone has any comments.
Does anybody feel the US fell short in their guidelines compared to Europeans?
That's a loaded question.
Because I'm still having discussions with my colleagues who think that the absolute risk reduction is not enough and really are reluctant to embrace it. And it's, I think sometimes the guidelines, the job of the guidelines is to kind of make people do the right thing. And I think they fell short.
Roxana, you were on the guideline committee, so let's put Roxana on the hot spot.
Well, the way it works is that you can give your opinion, but when you have relations with industry, you can't vote. So the voting is really relegated to the no conflict. The conflict of interest is taken extremely seriously, and obviously I've received grants based on all of these trials that we've done. And the involvement, and so therefore I was not able to vote. But having said that, I think I would say, we have a chance now. We're doing a revascularization guidelines now, and hopefully there'll be updated guidelines based on all of the data that have come in. I think that overall they felt that both the Triton TIMI 38 as well as the PLATO study was designed in a way to make the Clopidogrel, that's how they felt, that the Clopidogrel arm was somewhat, weakened by the fact that they didn't have a chance to get the drug on board, et cetera. And so therefore, it didn't feel like it was like a fair comparison. It's sort of the same with Cangrelor, for example. But I think, we have this clear-cut evidence now based on so much data that these potent agents really do improve definitely the early outcomes and could have important lasting improvement on outcomes on these patients, as long as we can keep them from bleeding and that we can really, really choose that well, especially in the long run. And I know that we're going to be covering that a little bit later. But I agree. I think we're a little bit behind the Europeans.
Yeah, I wasn't sure what you meant though, Bryan, when you said we're behind in respect to what specifically from the guidelines.
Well, I just think that, you know, the Europeans tapped Ticagrelor as the, you know, as favorable, and I think they gave, the guidelines gave an equal status to Clopidogrel. I see now what Roxana is saying, and I understand that a little better. But as I said, I've had some difficulty getting people to embrace Ticagrelor in the setting of, particularly in the setting of acute MI. And it's based on what they perceive as a small absolute risk reduction, and the fact that the guidelines don't really favor one over the other. And it's, you know, it's a challenge.
Yeah, but I see both the US and the European guidelines do favor more potent agents in general. That is, Shamir just showed the US guidelines that do give some preference there to Ticagrelor versus Clopidogrel, what he showed, and likewise the guidelines do give some preference to the more potent agents.
Deepak, if you go to the, you're right, but if you go to the table, they both have class 1A recommendation. So that's so whereas the Europeans will say, oh, don't give Clopidogrel unless there is, you know, sort of, you really should go to Ticagrelor or Prasugrel, especially for PCI patients, even Prasugrel there. But the US, if you look, you know, they all have class 1A, all three, all you know, P2Y12 inhibitors.
So you're absolutely right. I was just trying to be nice. I think the European guidelines get it right, because they're not so worried about somebody criticizing and saying, oh, look at this US guideline writing committee. They're so biased. They're given these expensive prescription medications a class 1 recommendation, outrageous. You know, Dr. Mehran, take her out back and shoot her. You know, that's the concern I think that the US guidelines have. Unlike the Europeans, are like, whatever, you know, people want to criticize, they criticize. And I think, all kidding aside, that's why sometimes the US guidelines don't fully respect the data, but instead are sort of, you know, cautious and worried about being second guessed, especially when a greater degree of preference is given for a more expensive branded agent, is my own opinion.
Well, thank you very much, Deepak and Roxana. Great discussion. Let's continue with the program. It's a great privilege to now introduce Dr. Deepak Bhatt, who really requires no introduction. However, is a renowned physician. Was keynote speaker for 2019 C3 program in our 15th year anniversary year. He's a senior physician at Brigham and Women's Hospital. He's the editor of the Harvard Heart Letter at Harvard Medical School. He's also professor of medicine and a renowned interventional cardiologist who's played a key role in multiple research trials, including several clinical trials of acute coronary syndrome. So his topic today is what P2Y12 inhibitors to choose in acute coronary syndrome and when to start, the role of genetic testing and evidence-based discussion.
Great, well, thank you for that very kind introduction. And it was great being at C3 last year live. It was a lot of fun, but this is shaping up to be as much fun, this virtual panel here, with a lot of really great luminaries in the field, and more importantly, a lot of great friends. So my topic is the role of genetic testing in choosing P2Y12 inhibitors in ACS. I should first disclose, I didn't pick this topic, I was assigned it. I'm not really sure that I would be using genetics myself right this instant, but I was asked to do this, so I'm doing it. These are my disclosures, and ones that are potentially relevant to my talk or comments is that I did receive honorary for the Mayo Clinic for my role for chairing the DSMB for TAILOR PCI, which I will be discussing, as well as research funding from AstraZeneca, Bristol Myers Squibb, Lilly, Phase Bio, and Sanofi Aventis for various trials of Clopidogrel, Prasugrel, and Ticagrelor, as well as a Ticagrelor reversal agent. So the platelets are really important. I think everyone tuning into this symposium knows that, otherwise you wouldn't be tuning into this symposium. They're central to acute coronary syndrome, central to percutaneous coronary intervention, its complications, and in particular, patients with ACS undergoing PCI are subject to platelet-mediated thrombotic complications. And the ADP receptor is really central in preventing those complications. Clopidogrel and prasugrel are both prodrugs, and they're active metabolites, bind to the P2Y12 receptor, whereas ticagrelor is a direct-acting P2Y12 receptor, but antagonist, but they're all working generally on that same receptor. Now, prasugrel is basically a more potent version of clopidogrel. It's more efficiently absorbed and metabolized, but still does need to be metabolized. But because of its more efficient metabolism, is less prone to different polymorphisms that may hamper the metabolism of clopidogrel. And ticagrelor does have a pathway that goes through the liver, but doesn't really need to go through the liver. So those sorts of polymorphisms that affect clopidogrel, various polymorphisms of CYP2C19, aren't really relevant when we're talking about ticagrelor at all. But a challenge before getting into whether we should use genotyping is that as a general principle in human beings, if you intensify platelet inhibition, you are navigating between Scylla and Charybdis, a rock and a hard place. More is definitely better. Longer is definitely better in terms of reducing important complications such as myocardial infarction and stroke and stent thrombosis, sometimes even cardiovascular death. But the downside, there's always an increase in bleeding, always an increase in minor bleeding and major bleeding. And if you study enough patients for long enough, fatal and intracranial bleeding as well. So that's the real challenge. Can we optimize that though? Well, before getting into genetics, I think it's important to talk about not the fancy stuff, but the simple stuff, maybe the stuff that's not so exciting. Things like adherence that really, in my opinion, dwarfs the importance of platelet function testing or genetic testing or tweaking things at the edges. When you realize that a good chunk of patients aren't even taking their ADP receptor antagonists at the time, shortly after discharge, at a month, certainly a few months afterwards. And some of this is due to side effects, some of it's due to bleeding, sometimes it's due to cost. But even when we're talking about generic medicines such as clopidogrel these days, there are still issues with non-adherence. So yes, we should think about how can we do better in terms of the science, but some of it is probably more simple in just dealing with the implementation science. Now, going back a bit in time, there were a slew of studies in the, I guess I'd say the late 2000s, where it was shown that various genotypes affected clopidogrel responsiveness, in particular CYP2C19 polymorphisms. Various permutations would lead to less clopidogrel effect. And it would seem logical then that patients that had CYP2C19 reduced function alleles, especially homozygotes, might be in particular risk of having ischemic complications if they were on clopidogrel as their ADP receptor antagonist. Certainly very logical, very intellectually appealing to then tailor antiplatelet therapy based on pharmacogenomics. It sounds very elegant and scientific, and physicians like to think of themselves as scientists, so it all sounds pretty good. However, when looking at the really large pivotal trials as done here by the cure and active investigators, Shamir, Mehta, and others, and I was fortunate to be part of this, they took me along for the ride. When looking at cure and active, two large, well-done trials looking at clopidogrel effect, clopidogrel bleeding versus placebo, and the impact of genotype, well, the bottom line is for efficacy, clopidogrel beat placebo regardless of the genotype. And for bleeding, it also caused more bleeding versus placebo, of course, but regardless of genotype. So it wasn't clear, despite the theoretical appeal in this actual randomized clinical trial of clopidogrel versus placebo on top of aspirin, what added benefit, if we had a knowledge of genotype, it would have provided. So a little bit of a downer there with all that excitement about genotyping, but then the data didn't really support that it would have been valuable if we could have gone back in time and used that data. And that was cure and active, but charisma basically was the same thing, where we didn't find any significant interaction between genotype and efficacy. And Dr. Mehta was part of this particular analysis as well. So, three large randomized clinical trials of clopidogrel versus placebo, not showing any sort of interaction for efficacy. And for the most part, not with bleeding. I should say in charisma genetics, we did see an association with minor, though not major bleeding. So maybe there was a little something there, but again, not something really actionable. Then, of course, we can consider PLATO. Dr. Mehta did a nice job reviewing the clinical PLATO. Here's PLATO genetics as published in the Lancet. And it's sort of a similar story to the clopidogrel trials. Those were clopidogrel versus placebo. This is, of course, ticagrelor versus clopidogrel. But with respect to efficacy, regardless of the patient's genotype, ticagrelor beat clopidogrel, so to state, for ischemic endpoints. And that was true for any variety of different ischemic endpoints. And furthermore, in patients that had a reduced function or loss of functions called here, genotype for clopidogrel, the benefit of ticagrelor was even greater and earlier emerging than if they didn't have that. So yeah, if you had a quote unquote bad clopidogrel genotype, that made ticagrelor even more better. But even if you didn't have one of those genotypes, it was still better. So again, it wasn't clear that this knowledge of genotype, if one had it and could travel back in time and use it, would have necessarily been useful. That was efficacy. It was the same story for bleeding, where the overall PLATO bleeding results were mirrored here without any significant influence of the genotype, where there was increased bleeding if you looked at non-cabbage bleeding with ticagrelor versus clopidogrel. Now, for major cabbage bleeding, if you recall, it actually wasn't increased with ticagrelor, but likewise, same story here. So really the knowledge of the clopidogrel genotyping, it seems, wouldn't have really helped us decide between clopidogrel or ticagrelor anyway. So all those randomized clinical trials really don't change the basic calculus. But most recently then comes along TAILOR PCI. This was just presented as a late breaker at the ACC by Dr. Pereira and colleagues from Mayo Clinic and the NHLBI and Canada. Dr. Farku was one of the co-PIs, Chet Rihal also a major leader of this trial. So a really interesting study. As I disclosed, I was part of the data monitoring committee as the chair. And the way this was designed was it was a two-arm parallel open label international multi-center randomized superiority trial. So all the right stuff. The open label, of course, not perhaps what you would want, but it didn't seem feasible to do it any other way. The patients were those who were undergoing PCI for ACS or stable CAD, believed to need 12 months of DAP. And the major exclusion criteria were failure of the index PCI. If you knew the CYP2C19 genotype, well, then it wouldn't have made sense to enroll in any sort of planned revasc within 30 days. The overall study design is shown here. So patients had to undergo coronary angiography and then PCI. They were screened and consented, of course, and then they were randomized if they consented to conventional therapy or genotype guided therapy. Conventional therapy was clopidogrel 75 a day. And of course, you might argue whether prasugrel or ticagrelor would have been appropriate in the ACS subgroup, but regardless, this was what it was, clopidogrel 75 a day. Genotyping occurred, and then they were binned into being non-carriers or carriers of the CYP2C19 reduced functional alleles, star 2 and star 3 specifically. And then there was a genotype guided therapy strategy, and there the patients, if they were carriers of CYP2C19 reduced functional alleles, got ticagrelor 90 BID, and if they weren't, got clopidogrel 75 a day, also genotyped and binned into those who were carriers and non-carriers. The primary analysis cohort is in the box here. So within carriers, comparing those that had gotten Ticag versus those who had gotten clopidogrel. So it's a lot to follow, multiple different aspects to the trial. The primary endpoint was the composite of a bunch of different ischemic events. The secondary endpoint was bleeding, of course, and the study endpoints were adjudicated. So in terms of the statistics behind it, there was, I should say, an ambitious sort of goal, in large part, I would say, driven by budget, where the hazard ratio was hypothesized to be 0.50. Obviously, that's a lot to ask of any contemporary therapy on top of other therapies. There's always a challenge of showing incremental benefit in cardiovascular trials because we're overall doing a pretty good job, but it was a 0.50 hazard ratio that was assumed. And 5,000 patients were randomized, 2,600 into the genotype guided therapy, 2,600 into conventional therapy. This is the basic flow, and it ended up with a bit over 900 patients in this primary analysis in the two groups for a total of 1,849 patients. And again, these are CYP2C19 star 2, star 3 carriers who had been randomized up here to either receiving the Ticagrelor or the Clopidogrel. These are the primary results. As I said, a composite of various ischemic events, conventional therapy in blue, genotype guided therapy in orange. And as you can see, there is or isn't a significant difference depending on how much of a stickler you are for p-values. But if you believe in a p-value of 0.05 or less, this unfortunately fell just a little bit to the wrong side of the 0.5. So strictly speaking, the trial did not meet its primary endpoint. Now, on admittedly a post hoc analysis, what the investigators found was during that first 3-month vulnerable period where stent thrombosis and ischemic events are particularly high after PCI, there was a hazard ratio of 0.21 and a p-value of 0.001. So it did appear that there was potentially some early action going on, with the major caveat that that was post hoc done once the investigators were unblinded to the data and the results. Here's the safety endpoint, no difference in bleeding between these two strategies. Now, this is a pre-specified analysis that I'm sharing with you. Multiple recurrent events, which has been a popular way, at least in atherosclerosis trials recently, at looking at events, not just the first event, but subsequent events. So somebody that has stent thrombosis and then 3 months later has say a stroke or a recurrent ischemia episode or something like that, or dies from cardiovascular causes. So total events. And here the hazard ratio in this pre-specified sensitivity analysis was 0.6, a p-value of 0.01. And these are the curves. So at least for people that really want to believe in genotyping, it looks like there might be something here with a little bit of added statistical power that is granted by looking at more events than in the primary endpoint. So what the investigators concluded was that a genotype-guided strategy of oral P2Y12 inhibitors compared with a conventional Clopidogrel strategy without any sort of point-of-care genotyping in ACS and stable CAD patients undergoing PCI resulted in no significant difference in reducing ischemic events at 12 months based on the pre-specified analysis and that 50% treatment effect that the study was powered to detect, which, as I mentioned, was a rather ambitious goal, perhaps in large part driven by budgetary concerns, and that there might be a potential benefit to this approach in the first 3 months after PCI in particular, and for reducing multiple ischemic events. But both those statements need to be interpreted in light of an overall p-value for the primary endpoint that didn't meet statistical significance. Bleeding rates were similar between the two strategies, and I think importantly, the NHLBI has kindly agreed to fund an extension, so extended follow-up is ongoing, so perhaps this will give even greater power to see if further events are accruing in a differential manner between the two different treatment arms. I've just got to provide before closing, and I'll try to stay on time here, a breaking update regarding various things pertinent to the field, not necessarily of genetics, but to antiplatelet therapy. These were the current FDA approvals for a variety of different indications for Clopidogrel, Ticagrelor, and Prasugrel. Clopidogrel and Ticagrelor having a few more in the way of indications, Prasugrel really being ACS plus PCI based on Triton, as reviewed by Dr. Mehta. But on June 1st, Ticagrelor was approved by the FDA to reduce the risk of a first MI or stroke in patients with coronary artery disease at high risk for such events. So actually a broad label in patients at high ischemic risk, but of course low bleeding risk. And that's based on THEMIS and THEMIS PCI studies, which Dr. Mehta, by the way, was on the executive committee for. So then to conclude, my thoughts, not just about genotyping, which, as I said, I think we've got to sort of wait and see what the paper says when it is hopefully ultimately published, what the longer term follow-up show. But more broadly, I think the fundamentals actually remain unchanged. That is, in ACS, at least 12 months of DAPT with Clopidogrel, Prasugrel, or Ticagrelor is recommended if there's no sort of bleeding issue. And if the patient is at low bleeding risk, Prasugrel or Ticagrelor would be preferred. In my own practice, it's Ticagrelor, based on the mortality data that Dr. Mehta had shown. And if they're at high bleeding risk post-PCI, I think now you can safely abbreviate the DAPT at 3 months, and that's based on extrapolations from trials such as Twilight that Dr. Mehran led, but also Stop DAPT and other trials, Smart Choice, that suggest shorter might be okay. And at that point, I think Ticagrelor is the preferred agent for monotherapy based on Twilight again, though Clopidogrel monotherapy could be considered in patients at particularly high bleeding risk based on Japanese and Korean studies. And finally, in patients that are post-MI, that have diabetes, complex stenting, and or that de facto means complex underlying coronary artery disease, I would still consider longer durations of DAPT even beyond a year. And the Ticagrelor US label has been updated based on Themis and Themis PCI for CIED. So now that practice actually is an evidence-based one, though it's been going on for a while based on Pegasus with Ticagrelor and in an off-label fashion based on Charisma with Clopidogrel. Well, thank you very much for your attention, and hopefully that quick review of old and new in genetics was useful.
Thank you very much, Dr. Bhatt. We do have one question from the audience. What type of a patient who has no stent before that you, with coronary artery disease diagnosis, you would prescribe Ticagrelor to?
Yeah, I think that's a terrific question. I mean, in general, I think the data are strongest for Ticagrelor in stented patients. So, you know, even within Themis, the results of Themis PCI were stronger. So I think as a general principle, where I use DAPT is in patients who've gotten a stent, often for an ACS, but sometimes, you know, complex stable CAD, where in those sorts of patients, if they haven't had a problem at a year, you know, I typically will continue it longer. But in a patient that has never been exposed to DAPT, hasn't been on DAPT either in the past or currently, I typically wouldn't just de novo initiate dual antiplatelet therapy, other than in very rare circumstances. You know, somebody that's just having multiple ischemic events is being medically managed for their ACS because, you know, maybe diffuse disease, maybe a type 1 diabetic where they don't have good distal targets for CABG and disease is too diffuse for stents. That sort of patient, you know, I might consider. I had been treating in the past with aspirin and Clopidogrel. You know, I might consider now aspirin and Ticagrelor. It would certainly be on label. Another option, though, for that type of patient is aspirin and vascular dose rivaroxaban. I didn't have time to get into any of that, but that would be another on-label option for high ischemic risk CAD and PAD patients that are at low bleeding risk. So, you know, one of the problems, and I'm sure we'll get to this at the panel, is that we have a wealth of choices right now, right? You can go shorter, you can go longer, you have DAPT, you have flavors of DAPT, you've got the rivaroxaban at a vascular dose. So there's all sorts of potential considerations, but I try to keep things simple. If a patient's doing well on what they're on right now, I tend to continue it and not rock the boat. And as that pertains to DAPT, if they're doing well on dual antiplatelet therapy, you know, in general, I tend to continue it long-term, but I reassess for side effects, most prominently bleeding.
There is one more question, which is actually to the entire panel. Is ASCVD risk calculator able to help with Brilinta benefit in stable CAD?
Yeah, that's an interesting question. And just to be clear, because, you know, the label, the way it, some have reported in the media was inaccurate. That is, some people sort of misinterpreted it as primary prevention. Now, of course, the terms primary prevention, secondary prevention, it's all a bit blurry, but really what it refers to is secondary prevention. That is, patients with established coronary artery disease. Within the trial, Themis PCI, it was angiographically determined CAD, at least a 50% stenosis treated medically, percutaneously, or surgically in the past. So for a patient who, you know, is just kind of a primary prevention patient where you might use a risk calculator to determine whether, you know, for example, they need a statin or something, you know, I wouldn't use the risk calculator to decide whether they need Ticagrelor. I mean, the decision there is, might they need aspirin for primary prevention? A contentious, controversial issue in its own right, I suppose. But, you know, there I think using risk calculators can be useful because if somebody's got, say, greater than a 20% 10-year risk, barring bleeding problems, I would consider aspirin a low dose for primary prevention. And if they have diabetes, based on the ASCEND trial, again, if they're at low bleeding risk, I would consider it, again, especially if they have multiple other cardiovascular risk factors in addition to diabetes, such as active smoking, despite recommendations to stop, family history of premature MI and a first-degree relative. But in terms of intensifying beyond aspirin in the primary prevention setting, I wouldn't do it. In fact, we showed in Charisma that that strategy didn't improve ischemic outcomes, but it did increase bleeding. But in terms of secondary prevention, I don't know that I would use that particular score.
Deepak, a quick question. Which are the advantages, in your opinion, of a genotyping strategy over a platelet function test strategy?
Yeah, I think that's a really great question. And again, I just stuck to my assigned topic and didn't get into platelet function testing. That too is something that seems like it should work, but hasn't been totally nailed down, though there have been some more recent trials that have been provocative and suggestive and supportive. You know, I think the real, so I don't do it other than for research purposes is the bottom line. And there might be some exceptional circumstances where I do it. Somebody keeps coming in with recurrent stent thrombosis. Somebody comes in with stent thrombosis and they say, oh yeah, I'm adherent to my antiplatelet therapy. I mean, it's a good way to check and see, were they really adherent to their antiplatelet therapy? But usually the answer ends up being no, but it can be an objective way of figuring it out. So in those specific circumstances, I think there is some value. But for the average patient coming in, I'm not sure it makes sense. I mean, let's say you stent an 88-year-old woman that weighs 43 kilograms, whose creatinine is 1.8. In that sort of patient, if the platelet function test or the genotyping comes back and says intensify to Prasugrel 10 milligrams a day, to Ticagrelor 90 BI a day, you know, is that necessarily a good thing to do just based on the test? I don't know, because you might expose that patient to bleeding hazard, you know, for a theoretical benefit on ischemic outcome. So I guess I'm still waiting for more definitive data. I'm hoping TAILOR PCI might provide more with additional follow-up. And with respect to platelet function testing, I'm hoping that future studies can nail it down, maybe with better assays that study thrombosis globally, not just focused on one particular pathway to platelet inhibition. So I guess I feel like we're not really there yet. As far as I'm concerned, if you have access to a more potent antiplatelet therapy, use it. If the patient's at high bleeding risk, don't. Stick with Clopidogrel. And if cost is an issue, then use generic Clopidogrel. And for that matter, Prasugrel is going generic in many regions of the world, including the US. So, to me, I think the real issues are bleeding, side effect, and cost. And that's how I really make these decisions, as well as based on ischemic risk, not so much on genotyping or platelet function testing. But I think both are interesting, both merit further study. And I can envision a future world where we actually are incorporating those into clinical care.
I guess I feel like they kind of missed the boat, unfortunately, with TAILOR PCI, that the real benefit was early on, but this was sort of an afterthought. And longer period of time, I can tell you just even from the Twilight study, there's only for so long that patients could stick to a regimen that a doctor assigns them to. And as time goes on, other things happen and things change and people make, so I don't think that the longer term follow-up from TAILOR PCI is going to show us anything. I think, unfortunately, the boat was missed in the early period where there is really all the meat and all the benefit early on. And I think after 3 months, I think it's a different story where we need to maybe go down to a single antiplatelet regimen and think about what we should give to the patients then. I just feel that I thought I had to say that, but I don't know if I'm correct. You might be right. They may get something with the longer term follow-up.
Yeah, I don't know. I mean, I think you raise really good points. I was just trying to be optimistic and hopeful. It would have been better if the budget had allowed greater powering for early events. There's really little question about that. But, we've got what we got and just got to hope to extract as much knowledge out of it as possible. But, you're right. It's interesting with ACS or high-risk PCI, most of the events are up front the first week, month, 3 months, and after that, it really tails off. But then there is sort of a second kind of wave, so to speak, where, for example, in Themis PCI, we really didn't see the curves diverging until after a year of therapy. So, I mean, if you follow the patients long enough, there are more events that are accumulating. Whether they'll stay on their assigned therapy that long is a really valid point. They may not, especially in an open label trial, without careful sort of monitoring and making sure the patients are staying on their Ticagrelor in particular.
Okay. All right, great discussion. Thank you very much, Dr. Bhatt. As always, a phenomenal talk. Let's continue with the program, and it's now my pleasure to introduce Dr. Tullio Palmerini from Italy, who is a professor of cardiology at the University of Bologna, and also senior interventional cardiologist at Polyclinic S. Orsola in Bologna, one of the biggest and the largest hospitals in Italy. He's also been a principal investigator for many different clinical trials in Italy, and has been first author for numerous peer-reviewed papers as well as textbook chapters. So it's great pleasure to have my good friend Tullio Palmerini to talk about who are the right patients for long-term DAPT strategy.
Thank you. So there are at least 20 randomized trials with more than 50,000 patients investigating the optimal duration of dual antiplatelet therapy after drug-eluting stent implantation. So the summary of evidence as collected in this meta-analysis suggests that longer DAPT significantly reduce the risk of stent thrombosis and myocardial infarction, not related to the stented artery, but significantly increase the risk of bleeding. And bleeding is associated with an increased risk of mortality. In this meta-analysis of 12 randomized studies for which we had individual patient data for 6 of them, the risk of mortality after bleeding was 18.8%, and bleeding was an independent predictor of mortality. But more importantly, longer DAPT was associated with an increased rates of bleeding-related death as compared to shorter DAPT, whereas there was no difference in non-bleeding related death between the two DAPT duration. And this is important because for the first time, it established a link between dual antiplatelet therapy duration, the risk of bleeding, and the risk of mortality. So there are many variables associated with ischemia and many variables associated with the bleeding. But the tricky part in disentangling the risk of bleeding from the risk of ischemia is that many variables are shared between these two events, such as age, complex coronary artery disease, anemia, chronic kidney disease, leukocyte count. So who are the patients that may be good candidates to longer DAPT, and for whom there is some evidence that longer DAPT may be of benefit? First of all, patients at low risk of bleeding. There is some evidence, and we will discuss it in a moment, that if you have a high risk of bleeding, prolonging dual antiplatelet therapy may indeed increase the risk of bleeding without providing a clear benefit. Then patients with acute coronary syndromes or prior myocardial infarction, patients with complex coronary artery disease, young patients, patients with recurrent myocardial infarction or stent thrombosis. This is the impossible question. If one patient is at high risk of bleeding and he is at high risk of ischemia, who wins? And how long we should recommend dual antiplatelet therapy? This is the issue that the authors of this paper tried to address. It's a meta-analysis of a randomized trial, almost 15,000 patients, in which patients were stratified according to DAPT duration, the risk of bleeding as measured by the precise DAPT, and the complexity of coronary artery disease. So on the upper panels, we can see patients at low risk of bleeding, and you can see that longer dual antiplatelet therapy significantly reduce the risk of ischemic event as compared to shorter DAPT, irrespective of the complexity of PCI, although the effect, the magnitude of the effect was greater in patients with complex PCI. In contrast, in patients at high risk of bleeding, long dual antiplatelet therapy did not reduce significantly the risk of ischemia. So let's see the detail, the data, the results in more detail, looking also at bleeding, ischemia, and the net benefit. In patients at low risk of bleeding, longer dual antiplatelet therapy does not significantly increase the risk of bleeding, whereas it reduces the risk of ischemia. And the magnitude of the effect is greater in patients with the complex PCI, such that the net benefit is in favor of longer DAPT, especially in patients with complex PCI. But now let's look at patients with high bleeding risk. Longer dual antiplatelet therapy significantly increase the risk of bleeding without reducing the risk of ischemia. Indeed, the number of ischemic events were even higher in patients with longer DAPT, such that the net benefit was in favor with shorter DAPT in patients at high bleeding risk. Of course, this is just one study. It has many limitations, and at least to me, at the end of the day, the question is how much is the risk of bleeding versus how much is the risk of ischemia to tailor the optimal duration of dual antiplatelet therapy. We know that patients with acute coronary syndromes have increased risk of events as compared to stable patients, and this makes them the ideal candidates for prolonged dual antiplatelet therapy. Indeed, this paradigm has not been confirmed in some recent study which addressed the optimal duration of dual antiplatelet therapy in patients with acute coronary syndrome and avoid drug-eluting stent implantation. All these studies challenge the notion that after drug-eluting stent implantation in ACS, you need long dual antiplatelet therapy. But to me, the absence of benefit is due more to the limitation of this randomized trial rather than the reality that there is a lack of benefit of long DAPT in patients with acute coronary syndrome. SMART date 6 months was non-inferior to 1 year DAPT, but then if you look at the individual component of the composite endpoint, myocardial infarction was higher with 6-month DAPT as compared to 1 year DAPT. Reduce 3-month DAPT again was non-inferior to 1 year DAPT, but again, if you look at the individual component of the primary endpoint, all were in the wrong direction. 3 months DAPT was associated with higher rates of all-cause mortality, cardiac mortality, myocardial infarction, stent thrombosis. DAPT STEMI 6 months DAPT was non-inferior to 18-month DAPT for a composite of ischemic and bleeding endpoint, but of the expected 1,000 patients, only 870 were finally randomized. The observed event rate in this trial, 4.8%, was lower than the expected event rate, 15%, and thus the non-inferiority margin was disproportionately high, and any revascularization was a component of the primary endpoint. And we know that DAPT has no effect on restenosis, which is the main determinant of revascularization. And finally, the TICO trial, 3 months DAPT with Ticagrelor were superior to 12 months with Ticagrelor and aspirin. But again, the expected event rate was 18% and the observed event rate was 6%. The randomization was performed at the time of PCI and not at the time of DAPT discontinuation. And this is a trial performed only in South Korea. We are aware of the Asian paradox, according to which prolonging DAPT in these patients increases the risk of bleeding without reducing, having less effect on the risk of ischemia. So if we move to more powered trials, the scenario looks different. This is a sub-study of the DAPT trial, and you can see that patients with acute coronary syndromes, longer DAPT significantly reduce the risk of ischemic event as compared to shorter DAPT, whereas only a trend was apparent in patients with stable ischemic heart disease. To study more in detail this issue, we performed this aggregate database meta-analysis, including 6 randomized trials, more than 21,000 patients. And we included only trials that compared 1 year or less DAPT versus longer than 1 year DAPT. And indeed, we found that longer DAPT significantly reduced the risk of myocardial infarction, both in patients with ACS and in patients with stable ischemic heart disease. But it does more so in patients with ACS as compared to patients with stable ischemic heart disease. And if you look at bleeding, longer DAPT increased the risk of bleeding in patients with stable ischemic heart disease, but not for some reason those with ACS, such that the net benefit combining myocardial infarction and bleeding is in favor with the longer DAPT in patients with ACS, but not in patients with stable ischemic heart disease. And you can see that the P4 interaction is significant. So the issue of prolonging dual antiplatelet therapy with Ticagrelor in patients with prior myocardial infarction was addressed in the Pegasus trial. So in the Pegasus trial, both 60 and 90 milligram doses of Ticagrelor significantly reduced the primary endpoint of cardiovascular death, myocardial infarction, and stroke. But this happened at an increased risk of bleeding. Now, if we make a balance between bleeding and ischemia, the 90 milligram Ticagrelor dose versus placebo appears not to be associated with a very favorable balance, because we have 40 fewer MACE and 41 more major bleeding. But the balance is definitely better for the 60 milligram Ticagrelor dose, because we have 42 fewer MACE as compared to 31 more major bleeding. So in order to maximize the benefit of ticagrelor in these patients, we have to identify those patients who are likely to benefit the most from this therapy. And here we can see that patients with multivessel disease seems to derive more benefit than patients with no multivessel disease with prolonging DAPT with ticagrelor, with a trend for an interaction for coronary death, myocardial infarction, definite stent thrombosis, coronary death, and stent thrombosis alone. And the same was true for peripheral arterial disease. You can see that there is no interaction, but the magnitude of the effect was greater in patients with the peripheral arterial disease as compared to patients with no peripheral arterial disease. And similar findings were apparent for Pegasus and diabetes. Again, no interaction, but the magnitude of effect was greater. Especially for coronary deaths in patients with diabetes, there was an absolute risk reduction of 1.1% in diabetic patients who using ticagrelor as compared to non-diabetic patients in which the absolute risk reduction was only 0.1%. So this is a patient with 75 years old patient with acute coronary syndromes. So we see that there is an obstruction of LAD, disease of the diagonal, an obstruction of the circle, and a disease of the right coronary artery. So this is a similar patient, similar for age, similar for risk factors, but here we see that this patient has only a lesion, a short lesion of the ramus. So it is well known that the complexity of coronary artery disease has an impact on prognosis. This is an analysis of the acuity trial, and you can see that patients in the upper tertile of SYNTA score have increased risk of death and increased risk of cardiac death, myocardial infarction, and target vessel revascularization. As is dual antiplatelet therapy duration a game changer in patients with complex coronary artery disease? This is a pooled analysis of 6 randomized trials, more than 11,000 patients. Here you have patients with simple coronary artery disease in blue, and you see that there is no difference in ischemic event, in ischemia, between patients treated with long DAPT as compared to patients treated with short DAPT. But if you look at patients with complex coronary artery disease and a complex PCI, then long DAPT is associated with significantly lower rates of event as compared to short DAPT. And finally, age. These data are drawn from the same data set as the previous analysis. So it's an individual patient data meta-analysis with 6 randomized trials, more than 11,000 patients. If you look at patients younger than 65 years old, prolonged long DAPT significantly reduce the risk of ischemia without significantly increasing the risk of bleeding. Whereas if you look at all patients older than 65 years old, there's not seems to be much benefit in reducing the risk of ischemic events with longer DAPT, and indeed there is an interaction between DAPT duration and age. But on the other hand, there is a significantly higher risk of bleeding with longer DAPT. So in conclusion, compared to shorter DAPT, longer DAPT is associated with reduced rates of myocardial infarction and stent thrombosis, but increased rates of bleeding. A tailored approach is advisable when deciding the optimal DAPT, where an ischemic and bleeding risk are balanced in individual patients. Patients with ACS, young age, complex multivessel coronary artery disease, and low risk of bleeding may benefit from prolonged DAPT. Thank you.
Thank you very much, Dr. Palmerini, for that great overview of where we should consider long-term DAPT strategy. Any comments from any panel members?
Well, I'd say that was really a great presentation, really brings into focus the challenge that we face as physicians in this area. I think this is why it always is such an interesting topic that gets covered in symposia. Lots of people attend because it just comes up every day in practice. And you know, there's a ton of data to interpret. There are a bunch of guidelines that are at times helpful, but it just comes down to ultimately just a physician and the patient you have in front of you and trying to weigh all these different, you know, ischemic and bleeding risks, either in your head or sometimes perhaps more formally with a risk score. I think that's really what it boils down to, trying to weigh these two things. It's just, you know, as Dr. Bonwald says, no free lunch with antithrombotics to date. Nobody's figured out a way of completely, at least in populations of patients, dissociating the ischemic benefits and the bleeding risks. And I think the key is, individualizing. But, one thing that I found useful, and this sort of draws upon two of the things you mentioned, Tullio, the precise DAPT, two of the things that I think are particularly good in that risk score is history of prior bleeding, because I don't think anything predicts future bleeding like prior bleeding. So I think that's a really good thing. And even if somebody had something that was sort of a temporary cause of bleeding that was fixed, cauterizing a GI ulcer or something, still, I think the fact that they bled before does put them at higher risk. And the second thing is anemia, which I think is often underappreciated, especially in older, more frail patients. And if they're anemic, even if they're not symptomatic per se or being treated for it, you've got to wonder why. Is there some covert source of small intestinal GI blood loss? Is there something wrong with the bone marrow? But at any rate, if they're starting off with anemia, they're not going to tolerate a bleed should it occur so well. It can really spiral. So, besides just using formal scores, and Paris is another great one that Dr. Mehran came up with. Just in my head, if I don't have a calculator or score around me, that's sort of my quick way of just screening. If they've got either of those things, in my opinion, they're high bleeding risk, and I don't consider more protracted durations of DAPT. There I abbreviate.
So Deepak, I think these are really great points. But to me, even if you look at bleeding scores with wise clinical judgment, I believe you can make better choices. For example, you mentioned that previous bleeding is a strong predictor of future bleeding. But I mean, there is a previous bleeding and a previous bleeding. So if a patient bled 20 years ago is really different from a patient who bled 6 months ago. This is not addressed by the score. In addition, if a patient has a source of bleeding which was fixed, for example, he had the polyps and now you have treated the polyps and now he's free of disease, of course, he has not the same risk of bleeding of a patient who has a prone bleeding lesion. So this is the reason, because to me, of course, you have to look at the variables contained in the score, but then you have to integrate these variables with the patient and your clinical judgment.
Oh, I totally agree with you. I mean, the bottom line of what you're saying is, in this area, perhaps more than many, you have to be a good doctor. I mean, you really have to, talk to the patient and figure out their history, maybe talk to their family, and really take a good bleeding history. So I agree with you. And I think risk scores facilitate that sort of conversation and thinking. Yeah, so I wasn't saying that risk scores aren't a good thing, but the reality is many physicians, unless it's integrated into point of care electronic health records, aren't calculating risk scores, whether it's bleeding, ischemic, CHADS-VASc, any of these things. If it's integrated into the electronic health record at the point of care delivery, then I think physicians do embrace them.
Well, Deepak, you're just saying rather than the has bled score, you can just say the patient has bled. That's about as simple as it gets, right?
That's right. Well, you know me, I like it simple, Mike.
Keep it simple.
Okay, thank you very much, everyone. Let's keep rolling. It's now my privilege to introduce Professor Roxana Mehran, who is Castle Connolly's top doctors in New York and renowned clinical trialist, and also my mentor when I spent time at Lenox Hill Hospital 2 decades ago. She now is Professor of Medicine and Director of Interventional Cardiovascular Research and Clinical Trials at Mount Sinai School of Medicine in New York, and has been leading multiple clinical trials and part of a variety of different clinical programs, clinical research programs in the country and the guidelines. So it's a great pleasure to have her here today. She is now going to talk about who are the right patients for short-term DAPT strategy and which antiplatelets do you stop.
Well, thank you so much, Dr. Dave and the entire group for inviting me, but to have me on this panel with these amazing, amazing dear friends. It's so nice on this Sunday evening to spend some time with all of you. So thank you so much. It's important for you to note my disclosures, and as you're looking at those, especially because I'm going to be speaking about the Twilight study a little bit, that the study was sponsored by the Icahn School of Medicine, but through institutional grant from AstraZeneca, I think it's an important disclosure to take away along with everything else here. And I thank Tullio Palmerini for putting out who should be getting prolonged DAPT. And honestly, I think we're going to come to a place where we should really be thinking about going to a single antiplatelet therapy and perhaps thinking better about which one instead of keeping those patients on a prolonged dual antiplatelet therapy for no clear reason that we can imagine. And I think it's important, especially with some of the sub-analyses that we're now seeing with these potent agents alone, to start thinking in that direction. But before that, based on all of the evidence, you can see from the US and the European guidelines that it really is about the shorter duration of DAPT. It's really, and you can see it very, very nicely here, that even depending on an acute coronary syndrome versus a stable coronary syndrome, when you get to the high bleeding risk patients, you begin to have a shorter duration of DAPT. And it makes a great deal of sense after we just heard from Tullio why this is, because the price of the bleeding is not worth the ischemic benefit in some of these patients. But remember that even those high bleeding risk patients are still at some level having a lot of ischemic events. In fact, if you look at those, it's much, much higher. The ischemic events are much, much higher than the patients not on high, not with high bleeding risk. So who are those patients? They're the patients that we previously did not enroll in clinical trials. Very old patients, severe chronic kidney disease, liver disease, active cancer, anemia, low platelet count, bleeding diathesis. And you can see that all here. And we have sort of major and minor criteria according to the ARC criteria that we came up with. And many of you, if not all of you, I think, are on this panel of the high bleeding risk ARC consortium. And I thank you all for all of your contributions. But the big question is, and I think that's what Tullio was trying to say, how do you prioritize and what do you prioritize? When does bleeding risk become more important than ischemic risk? And if you could figure that out, you can really devise a really nice strategy individualized for all of these patients. So we just saw, this is the there are several of these short duration of DAPT trials for the high bleeding risk patients. And we don't have that much time this evening to go on and on about all of them, but I'll just show you one. Here's the Evolve short DAPT. The trouble with all of this is with the Synergy stent. The trouble is that they're, for the most part, they're single arm studies, and they're looking at a previous sort of control arm that is never really been very, very well studied, and looking for, well, if we go to a 3-month duration of DAPT, could we, with this particular stent platform in high bleeding risk patients, could we meet the bar? And of course, you can see here that overall, over a period of time, death and MI alone, between 3 to 15 months, once they got off the dual antiplatelet therapy to a single antiplatelet therapy, and in this trial, for the most part, it was just aspirin, the death and MI rate was 6% during the next 12 months. That's a huge number. And you can see right here, 2% MI rate. The BARC bleeding is quite high, and you can see a lot of it was due to type 2, but still, these patients have large numbers of events. Their primary endpoint, of course, met their 12-month DAPT from their previous studies, and they just claim non-inferiority. And to me, historical controls are really limited in these. And I'm leading one of these trials, the Science program, 28 days and 90 days with a historical control. And I think it becomes difficult when you're looking at them and your control arm is that. But I guess my big question is, which antiplatelet do we stop? When we're talking about single antiplatelet therapy, are we just talking about going to aspirin? But let's understand that there's been some issues with aspirin, especially this past year or so in 2019, but also the question that begs the real answer is that if you have a strong P2Y12 inhibitor on board, what is aspirin giving you in terms of ischemic protection? And is it just exposing patients to undue bleeding risk? And to me, we should be starting to think about this scenario of withdrawing aspirin, and can we safely do this? And of course, the global leaders, investigators in over 16,000 patients, close to 16,000 patients, really came up with the strategy of a very simple experimental strategy of aspirin ticagrelor, and then stopping the patients, whether it was ACS or stable, at 1 month, not 3 months, at 1 month. This was open label, and the reference strategy, unfortunately, had multiple embedded comparisons, different for ACS than stable, and going to a whole year on stable CAD with clopidogrel. And we could understand all of this, but take a look. The primary endpoint was just a very, I would say, ambitious endpoint of reducing. They were powered and they said, we will reduce, we will be superior with this strategy in reducing non-fatal QMI and mortality and all-cause mortality at 2 years after randomization. Well, this was unfortunate because they just missed the endpoint, the p-value, and it doesn't matter. This is a negative study, even though the reference, the experimental group actually did have a lower, all the numbers are looking pretty good in this experimental group compared to the reference group, but it certainly was not superior. To me, non-inferiority is a win here. It's a win because it's the first time with withdrawing aspirin and showing it, but this was an open label study, and unfortunately, it didn't catch once you miss the endpoint. It's like you really didn't do this, and people move on. Well, the stop DAPT, and we talked about that already, and the smart DAPT, and I'll go through that very, very quickly. This is 1 versus 12 months, again, open label, but here, the P2Y12 inhibitor is clopidogrel, and we just heard that in Dr. Bhatt's talk, that there could be, obviously we have patients who have the CYP2C19 allele, and that they could have non-responsiveness, and we know that this is prevalent. It could be up to 30%. And so what you're basically doing in those non-responders, you're sending them home on an antiplatelet regimen that they may not be responding to. Nonetheless, with this, these great stents that we now have, over a 1-year period, the primary analysis for non-inferiority was met, and they said, well, we did a great job and things don't look any different. And in fact, we show that 1 month of DAPT followed by clopidogrel monotherapy, in fact, is showing a better MACE outcome because there is also reduction of bleeding endpoint embedded into death, MI, stent thrombosis, and stroke. And so you're seeing obviously, and then a non-inferiority towards the ischemic events. And so, yes, this is an important study, but I would still venture to say that we're underpowered for these, even at 3,000 patients. I would say you're underpowered for these rare events of death, MI, stent thrombosis, and stroke. Smart Choice was the study in Korea. Here, they looked at 3 different stent platforms, randomized them, stratifying it by center, and the type of P2Y12 inhibitor difference, but they basically had 3 months of DAPT versus the DAPT group that went for 12 months, and at the end of 3 months, they went home, or they received the P2Y12 inhibitor monotherapy, and this, again, was open label. Here, they showed, they felt, even though with these extremely low event rates, with death, MI, stroke at 12 months at 2.9 versus 2.5%, showing that they met the non-inferiority margin that they were looking for, and in fact, they lowered bleeding. Again, similar issues here compared to the previous study that I just mentioned. And we ventured to do this in with a lot of Shamir Mehta on the executive committee, Mike Gibson on the executive committee, and multitudes of investigators, coordinators, patients, everyone working around the globe and in 11 countries and close to 200 sites, looking at patients who had, whose clinician, the post-PCI would send them home on aspirin and ticagrelor, and they needed to have an additional clinical or angiographic criteria that would render them a high-risk patient, whether it's for bleeding. Some of these are for bleeding, some of them are for ischemic endpoints. And you can see it's the older patient, the female patient, ACS, PAD, diabetes, CKD on the clinical side, and on the angiographic side, all the things that Tullio just presented for complex lesion that you would really want to have prolonged dual antiplatelet therapies. 9,006 patients enrolled, and the difference here with all of these other trials was that they were enrolled, but they weren't randomized until they were seen at 3 months that they were adherent to their open label aspirin and ticagrelor, and they did not have major adverse events. Once that was done, 7,119 patients were assigned to ticagrelor plus aspirin versus ticagrelor plus a matching placebo, and we were very, very successful in seeing them over the period of time, doing pill counts, making sure they were adherent, and evaluating their outcomes and looking at their modes of discontinuation all the way throughout the study, with vital status available in almost 100% of the patients. The key primary endpoint here was a superiority hypothesis of reducing bleeding when you withdraw aspirin, and we met that very, very nicely. But our key secondary endpoint on a per protocol, it was really a safety endpoint, and we wanted to be sure that we would reduce bleeding without increasing harm on the ischemic side, and we absolutely did not, as you can see this here. So going for superiority here would have been a very, very big ask, and even in non-inferiority, we still say that when you don't have the event rates that you're expecting, that the event rates are small, you really should be cautious about these. Still, we're not seeing a signal of harm, and that was important. So we felt that by this particular strategy, you could continue ticagrelor monotherapy after 3 months. You will have less bleeding compared to ticagrelor plus aspirin without increasing ischemic events over a 1-year period, and we have not much after that, and I think that's an important aspect. We then, in this last ACC, and this was already presented by, this is another short duration of DAPT study, but here focused on the ACS patients, and I'm going to leave a lot of this to Dr. Gibson, who's going to cover ACS really, but in TICO, as you can see, they basically used very similar to Twilight, but interestingly, their endpoint was a net adverse clinical events that included the TIMI major bleeding and major adverse cardiovascular events, so ischemic plus bleeding endpoints. And you can see here they only had about 3,000 patients randomized, and they did show a reduction in the net adverse clinical events, and you showed that very, very nicely. Dr. Palmerini just showed that, which really gives you a finding that shows an absolute difference of 2% in the net adverse clinical events if you actually drop aspirin after 3 months. So the take-home messages, I think, is that you could have a safe approach in high bleeding risk patients, but you should note that when you're reducing duration of DAPT and you're going to aspirin alone therapy, you are exposing even those high bleeding risk patients to most likely ischemic events. And so how could we do a better job? Perhaps we should be rethinking this, rebooting the computer, and rethinking that dropping aspirin and continuing the P2Y12 inhibitor may even be better. Now, in a high bleeding risk patient, you may be very reluctant to give them a potent agent alone, and we really should be evaluating that. But I'm certain that in the high-risk patients, we probably should be using the potent agent, and ticagrelor has been tested, and and Dr. Bhatt explained that. But for the low to moderate risk patients, and especially those who are responsive to clopidogrel, I would be really, really moving in that direction, especially if you have a high bleeding risk patient. Thank you so much for your attention.
Thank you, Dr. Mehran. Any comments from the panel members?
So in the office, every surgeon in the state of Pennsylvania will not operate on Plavix. And so if you're only on Plavix, then you're sending a patient to surgery with no antiplatelet therapy on board, unless you switch to aspirin for their surgery and then switch back to either Ticagrelor or Plavix. Essentially, you've got to do more work to get those patients to go through surgery. I'm interested in the panel's reaction.
So maybe I should let maybe Deepak or maybe even Shamir, I don't know. You know, I personally think that if it's close, if the surgery is close to the time of, and you really believe that an antiplatelet regimen is needed on board, then you could use the Ticagrelor, and there was a bridge study that actually had taken place, and with a dosing strategy that's different than what we give right now. And I think it certainly is a viable option there, especially when it's very close to the surgery and you're worried about dropping the clopidogrel. But at the moment, you know, for elective surgery, I'm not seeing that the patients are going in, and most physicians are stopping clopidogrel, moving with some are even stopping the aspirin to try to mitigate the bleeding, depending on the kind of operation that's there. And I think it's an interesting dilemma, because we just have never done it this way. So this is the new way of dropping aspirin, and now our single antiplatelet regimen is clopidogrel, and aspirin is not on board. But together, it's a problem. It definitely is a problem.
Well, I mean, I think your surgeons that aren't operating on clopidogrel are essentially following the labeling. That is, you know, clopidogrel, prasugrel, and ticagrelor all say to stop before major surgery. And for, you know, prasugrel, you need about 7 days. For clopidogrel, about 5. For ticagrelor, really 3 would probably suffice, though many places it still says 5. So you might be stuck with that from a medical legal perspective, I suppose, if you're a surgeon worried about that sort of thing. But I must say, though, in general, when I send someone to cabbage, I'm fine with the surgeons stopping those things, because, again, they're just following the labeling and the guideline. But I would be a little hesitant sending them to surgery bare, that is, with no aspirin and no ADP receptor antagonist. And so if that's the choice, that is, they've come in, say, on clopidogrel monotherapy or maybe ticagrelor monotherapy post-twilight, you know, there I think I would then get them on Ticagrelor, as Dr. Mehran alluded to, in a bridging strategy. But I wouldn't be that excited, especially if it's an ACS patient or somebody with really bad anatomy, you know, a squeaky tight left main, or, you know, vessels with TIMI 2 flow, even if they were an outpatient. I'd be hesitant about just taking them off all antiplatelet therapy for a week and then, you know, hoping they're okay and bringing them for cabbage. So if that's what you were alluding to might be happening, in that case, I guess I would either initiate aspirin if the surgeon forced me to stop clopidogrel, or bridge with Ticagrelor. But I wouldn't let them just go completely bare, because I think there is some risk of thrombotic and ischemic events.
So, you know, I was going in the whole other direction. I'm not talking about major surgeries. I'm talking about yearly colonoscopies and the kind of routine surgeries where you're on dual antiplatelet therapy during that time. It's a simple matter to say, okay, stop clopidogrel for a number of days, go to surgery with the aspirin on board. If you're going with an antiplatelet monotherapy with a P2Y12 drug, the surgeon doesn't know that, you know, that they're only on one drug. They just want the clopidogrel stopped. They don't care. So what you must do now, at least what we must do now, is switch them back to aspirin, let them have their moderate procedure, then switch them back to you know, their original regimen. And so I think it will make things more complicated. It would be easier if at some point or another routine procedures with simply clopidogrel, for instance, you know, could be studied. I don't think that is.
But it has been. I mean, that is, so that practice then by your proceduralist is an illogical one. That is, if the concern is that aspirin, I mean, aspirin and clopidogrel have the same bleeding risk. So if one is going to do surgery on aspirin monotherapy, then it should be fine to do it on clopidogrel monotherapy instead. And, you know, there is the Capri trial after all. People don't often talk about it, but, you know, that was several thousand patients randomized to aspirin monotherapy and clopidogrel monotherapy, and clopidogrel did win for ischemic events. That's what led to the initial labeling and approval of clopidogrel for CAD, PAD, and even cerebrovascular disease. So, you know, Dr. Mehran has approved it with Ticagrelor in the contemporary era in the context of stenting and the value of Ticagrelor monotherapy, but Capri had put clopidogrel monotherapy on the map. And in terms of bleeding, there was no excess bleeding with clopidogrel versus aspirin. In fact, hospitalization for GI bleeding, that's one specific form of bleeding, was less, statistically significantly less with clopidogrel 75 versus aspirin 325, not 81, it was 325 in that study. So I don't think that that practice is logical, but proceduralists aren't always logical. So if you're saying they're just saying, you know, they're not going to do it, then they're not going to do it, and then you'd have to switch them to aspirin, I think.
Exactly. That's been you have to fight that battle with the procedurists every single time, and it's just it's a challenge.
Yeah.
Great discussion, everyone. Thank you very much. Let's continue with the program. It's now my great honor and privilege to introduce Dr. Michael Gibson, who is a professor of medicine at Harvard Medical School. He's a CEO of BAME Research Institute. He's pioneer in the field of cardiology, was keynote speaker of our 2019 C3 meeting and award winner. He's been leading investigator in multiple trials related to acute coronary syndrome. His name has been part of the world's most widely published and cited scientists. And it's a great honor to have him here this evening to talk about what is the future role of aspirin in PCI and ACS. Mike, the floor is yours.
Mike, you're muted.
All right, is that better?
Yep, we can hear you now.
All right, well, that's been the story of my life. Deepak, where are you throughout my life when I need to be unmuted?
Well, I came through this time at least.
At least this time you came through. But Raj, thanks for having me. Such a great meeting you put on every year. And this has been a great series. I've done a couple of these now, and they've been very informative. I learned a lot tonight. Well, let's talk a little bit about aspirin and what its current and future role is. I have research grant support from all major manufacturers of antiplatelets and antithrombins. They're all shown here. Well, this is an early ad for aspirin, and you know, they touted the fact that it does not affect the heart, that it was safe. It turns out it probably does affect the heart in probably an efficacious way, but it may not be as safe for other organs, as we all know. The question is this: we're not going to get rid of aspirin at the time of the PCI unless something else comes along. As you've been hearing tonight, more and more the question becomes, how long do you give someone aspirin? I think you're going to see the punchline is maybe a month may be sufficient. But the real answer is going to depend upon each patient's risk of bleeding and their risk of an ischemic event. You all know this. Aspirin inhibits prostaglandin synthesis, and prostaglandins are protective of the gastrointestinal mucosa, so you get some erosion and bleeding. At high doses, it can be a vasoconstrictor. It's not that potent. As we just heard, it's not as potent as clopidogrel. Even lower doses were even better with some drugs like Ticagrelor in some studies. And there have been now a series of studies that we're going to look at very quickly showing that dropping aspirin may reduce bleeding without a penalty in terms of ischemic events. This is what I find fascinating. You know, here we have all these new drugs come along, and we could have done several things. We could replace aspirin with those drugs. We never really did that. We always looked at number two, does the new drug add anything to aspirin? And all these drugs had to show they added something to aspirin. But what they also added was bleeding to aspirin. And now we're taking aspirin away and maybe replacing aspirin with those drugs. We never really looked. Does aspirin add anything to the new drugs? So which is more potent? You heard from Deepak earlier. The answer is Clopidogrel compared to aspirin. People forget about Capri, but Capri showed that actually Clopidogrel was superior to aspirin without more bleeding. Clopidogrel also added to aspirin and improved outcomes over aspirin alone in cure. But here's the opposite question. Does aspirin add anything to Clopidogrel? We never looked at that. We never looked at that in coronary artery disease. We only looked at it in stroke patients. And the answer is no. It did not improve efficacy outcomes in stroke patients when you add aspirin to Clopidogrel. All it did was increase bleeding, including life-threatening bleeding. So there have been a large number of trials, most all of which have now been completed, dropping aspirin. Just this week, hot off the press from Michelle O'Donoghue, here is a meta-analysis looking at all those recent trials outside of the setting of AFib. And what you see is no surprise. We look at global leaders, Smart Choice, StopDAP, Twilight, Tycho, post-PCI, here in a well-powered analysis, obviously a reduction in bleeding. But look over at MACE. Everyone was worried that you would have worse outcomes by dropping these agents, and that's just not what we see here. We actually see a trend towards more favorable outcomes, very close to being significant, by dropping aspirin. Now, that was PCI patients. Let's now look at ACS patients. These are at higher risk of ischemic events. You see the same thing. Obviously, reduction in bleeding, no surprise. But again, a reduction in ischemic events, very close to being significant here. So I've been critical of some of these short DAPT trials because they're small, underpowered, have broad non-inferiority margins. But I have to say, when you add all the data up, it really is compelling that there's not a safety signal in terms of efficacy when you drop aspirin. Same thing's been seen over on the AFib side. When you have triple therapy, take aspirin away. No surprise, as in Pioneer that I did, you see a reduction in bleeding. We're not talking about just any bleeding here. I want to direct your attention to the bottom line. This was fatal bleeding. When you look at the two Riva arms together, by dropping aspirin, there was less fatal bleeding compared to triple therapy. So it's not just a bunch of nosebleeds. Let's now add up all the data from all the trials. This is a new way of looking at safety and effectiveness plotted at the same time. The red kind of rectangle you see here in the center of that is the simultaneous plot of safety and effectiveness. You see it's over on the left-hand side here, meaning things were safer by dropping aspirin in AFib. But you see it's right on the line of unity. There is no excess risk of bleeding, or efficacy endpoints in the trials done to date. So safer, but no signal at the same time of excess ischemic events. This is the traditional way of looking at it. This is data published by Renato Lopez showing reduced bleeding, no surprise. But here, when you put together all the results, no excess risk of ischemic events. Now, I think this was a very important study that Renato presented recently, looking at timing. And there has been some concern in some studies about an increased risk of ischemic events early in the first 30 days. If you're going to have them, that's when they most often occur, in particular stent thrombosis. Well, this slide looks at the first 30 days. And what you see is that when you have aspirin as part of a triple therapy strategy, what you see is you get more bleeding, yes. But on the other hand, here's the silver lining, the good news. You did see a reduction in Augustus in ischemic events. So in those first 30 days where you had a high risk of ischemic events, aspirin looked like it was doing something important. However, this is the money slide. When you go 6 months or 30 days onward, you see a increased bleeding with aspirin on board, but you get no bang for your buck in reducing ischemic events with aspirin. This is a horribly flawed landmark analysis. I'll give you that. Once you reach 30 days, you're no longer randomized. It's an entirely different group of people, those who already survived without bleeding. So they are enriched for non-bleeders, but it's very provocative. It's very provocative that if you want to use aspirin, if you have someone who's at high risk of ischemic events, I think a message here is that maybe those first 30 days, that's when you get your most bang for your buck out of aspirin. And to kind of wrap up with some guidelines, a statement here, this comes from 2019 AHA-ACC statement, that you can reduce the risk of bleeding without a signal of ischemic harm by dropping aspirin. So I was given 10 minutes. I tried to stay on time. Thanks again for having me tonight.
Thank you very much, Dr. Gibson. Any comments from the panel?
Well, there's a question somebody sent through email. I think they probably think I'm Dr. Gibson's wingman or something, but the question they'd like to ask him is, what do you do after a year? Let's say someone with AFib and PCI or ACS or both, you said what to do for a year, but at a year, do you drop or continue antiplatelet therapy is the question they're asking.
Well, that's a real good question. You know, I think it's very complicated, isn't it? I mean, again, it depends upon risk and benefit. I think we have a real question in front of us. I mean, most people will continue aspirin and they will drop the thienopyridine. I guess I'd put before the group, is that the right choice? Should we instead give a thienopyridine, maybe a lower dose of Ticagrelor instead of aspirin beyond a year? I don't think we have data to guide us, but it is a very interesting question.
I can tell you that oh, sorry.
Especially in PAD patients, you know, we have a huge PAD practice, and you know, we have several patients with PAD that we continue just Ticagrelor and will drop aspirin.
And I have to say that I've actually started this in my own practice in my patients who I've had on aspirin and Ticagrelor after their STEMI that I've treated, and then they come back to see me. They're doing great. You know, if they fit some of the Twilight criteria, I am going to the Ticagrelor monotherapy, and I'm not worried about ischemic outcomes now. I have to say that there, and you all saw in the editorial that Patrick Serois wrote that, yes, you know, there's more strokes, you know, maybe there could be more strokes in a Ticagrelor monotherapy. And so I am assessing that as well as the risk of stroke, but I'm really, I don't know that that's a real finding. It might be, it may not be, I don't know. It's a small numbers of patients, but I am beginning to put the Ticagrelor monotherapy on board and feeling not so terrible about it, especially now with the Sydney study, which is a combination of both Twilight and all of the adjudicated, which is the glassy sub-study of the global leaders, and we have more power to show that this is really not the case and that things look pretty good with ticagrelor monotherapy.
Yeah, the stroke signal is interesting. I mean, it's a small number of events. I'm not sure what to make of it, but I would say separately, you know, in Charisma with ADAPT, we saw a significant reduction in the overall trial, not referring to subgroup, in stroke. In Pegasus, in the overall trial, we saw a significant reduction in stroke. And of course, in both cases, it was ischemic stroke, but all-cause stroke was in fact significantly reduced. And in Themis PCI, again, we saw significant reductions in stroke. And again, of course, it was ischemic stroke. So I think DAPT in high-risk CAD patients does reduce stroke, and in Compass as well, you know, we saw a reduction in stroke. So I think, you know, more does reduce stroke, but with caution, because of course there was the MATCH trial, a dedicated trial of cerebrovascular disease patients that didn't show a significant reduction in ischemic events with clopidogrel plus aspirin versus clopidogrel alone. It wasn't aspirin alone, it was clopidogrel alone. And there was more intracranial hemorrhage with DAPT, and that's what led to the reticence among the stroke guidelines to recommend DAPT broadly. No, but at least in CAD patients who have some indication for being on DAPT in the first place for some period of time, it does appear longer-term DAPT reduces the ischemic stroke risk. But the question, though, just to be clear, was an AFib patient. So maybe I'll answer the question was asked with my own opinion. I mean, there, I typically just go with an anticoagulant alone after 12 months. And
Yes.
maybe if there's super high ischemic risk and bleeding risk, we'll throw on more some clopidogrel. But in general, in the average patient, drop the antiplatelet if it hadn't already been dropped, and just continue a full dose, label appropriate adjustment is needed of a NOAC.
That's exactly what I'm doing as well.
Yeah, I agree. Me too. Somehow, Deepak, I thought I didn't realize as an AFib patient. Thanks.
Yeah, sorry. Thank you for that. Should we go on to the tough question you gave me next?
Yes.
Or
Absolutely. Absolutely.
Okay, good.
Roxana, thank you.
Thank you for putting me on the spot with this talk on the ISAR React, but I'm happy to do it. And so the question was, stick to the guidelines or change of practice, the deep dive into ISAR React 5 and some of the other recent publications. And certainly I think we already heard beautiful presentations by all of the previous speakers, especially Shamir, who started talking about the Triton and the PLATO studies, both really studies that allowed the two potent P2Y12 inhibitors to be now labeled for as a superior agent versus clopidogrel for treatment of ACS patients with prasugrel in ACS and PCI for ticagrelor ACS and whatever management you move forward with. And it was because of the fact that there was a reduction, without a doubt, on the primary efficacy endpoint, a reduction of cardiovascular death, MI, and stroke with both ticagrelor and prasugrel. And you see that here together, two publications over a decade ago for both favoring the more potent agent in ACS patients. And importantly, actually, when you look at it, they look very similar in terms of the event rates and the reduction, the absolute risk reduction as well as the relative risk reduction, about 20% reduction, 16 to 20% reduction. And you can see here that major bleeding for both of these agents, and while in the PLATO trial, it shows non-significant because it was a combination of CABG and non-CABG, but the truth be told that when you reduce ischemic endpoints with a potent agent, you will increase bleeding. We heard Dr. Brunwald said there is no free lunch, so there is more bleeding. But this was still felt that the magnitude of the benefit, especially with ticagrelor, with the reduction in mortality, was definitely in favor of using these drugs over clopidogrel for ACS patients. I think it's also important to note that in Triton, when prasugrel was being used, it was mostly, if not all, in PCI patients, whereas in PLATO, it was really an all-comers ACS patient population. And interestingly enough, to see that the drug-eluting stent use was quite low actually in PLATO. So if you look at the overall ACC/AHA 2016, you see that, you know, the 2A is what was given in the focused update for DAPT for ACS for Ticagrelor in preference to Clopidogrel and Prasugrel over Clopidogrel. Again, a 2A, and this is what we were just kind of quibbling about before. But which one? And I think the first randomized trial comparing to Ticagrelor and Prasugrel in acute MI patients was the Praga 18 study, and you could see here that really there was no significant difference between the two, and it looks like, but they were really truly a small sample size. It was prematurely terminated for futility, and things were sort of running in that direction, and it just didn't go. But I saw REACT-5 was in ACS patients looking at safety and efficacy of Ticagrelor versus Prasugrel in ACS patients who were having an invasive evaluation. This was randomized, multi-center, but open label. But what's important, and very, very important for everyone to understand, that there was a different schema, whether you had STEMI or non-STEMI, as far as when you received Prasugrel versus Ticagrelor. And I think that's an important one. And obviously in the STEMI patients, angiography and PCI, you can see at the time of randomization, they received it, whereas in non-STEMI, the time of randomization, Ticagrelor was given, then angiogram was done, then in the Prasugrel arm, it was given after the angiography, just like it was in the Triton study. So it's important to look at it as opposed to the previous trials. This was 4,000 patients as opposed to 18 plus thousand, 13 plus thousand in the Triton studies. And you can see here, very importantly, is that the timing is obviously much, much more current with the ISAR REACT-5. The stenting is much more prominent, very similar to Triton, 85%, 75% DES, hardly any 2B3A, but a open label as opposed to the double-blind way that Triton and PLATO were run. And you see the start and end. It took 5 years to randomize these 4,000 patients. And I think it's important to look at that. Obviously, this was more of an investigator-initiated study. What they did show, and they had powered this for a superiority of Ticagrelor over Prasugrel. They were looking to see that they designed it in that way, but actually found the completely opposite, where Prasugrel reigned supreme in terms of reduction of death, MI, stroke. And here, the lunch was completely free with no difference in the safety endpoint of BARC 3 and 5, in fact, having a little bit lower numbers compared to Ticagrelor for Prasugrel. So this right then and there, when I saw this be presented, I was like, wait a minute, something isn't fitting. But look, it could be that this is just the best drug ever. So should we change the practice now based on this? Because this really showed superiority. No, I mean, this is sort of the golden nugget. Let's give Prasugrel to everybody. Well, let's take a look at that. And I think it's important to think about that. The difference of an open label versus a double blind should never be underestimated. And I can tell you that we worked very hard for withdrawal of aspirin. We felt it was very, very important because of the bias that many of the investigators and clinicians and even patients may have for aspirin then and here, an open label design, and then having different time points versus and two drugs, that one is being given twice a day versus the one that's given once a day. It has a very, very important impact on how it should be evaluated. The other very important, and I didn't go through this to show you the low treatment adherence, such that 19% of the patients actually didn't receive the study drug at the time of discharge. And there was a lot more rates of Ticagrelor discontinuation, even though they only said they had 3% of dyspnea, which is kind of interesting because, you know, we could say that this was all due to dyspnea, but there was some for some reason, a BID versus a QD drug really, and you can see the difference here as I've listed it. So due to the imbalances, I think, in the treatment adherence and the number of patients excluded from the safety endpoint, the bleeding times, you know, the analysis on bleeding was 10 times higher in Prasugrel group than in the Ticagrelor group, but this was never obviously evaluated. The other very important thing, whenever you have a study that is smaller in number and then you don't meet your expected event rates, it really makes an important difference. And are there important issues in event ascertainment? Most of this was phone contact, 83%, and it was not really through a in-person visit, and they did use some structured follow-up using letters, and outpatient visits was only for about 10% of the patients. And the magnitude of the treatment effect was something else that we needed to kind of understand, because it was just nothing like we've ever seen before. And I think for ISAR React 5, that's where we start to kind of rethink this, that even in that, the rate of death, 4.5%, the rate of myocardial infarction for Ticagrelor being 5%, and the BARC bleeding even being higher, BARC 3 and 5 bleeding being even higher than that of Prasugrel in the same trial was questionable. And then lastly is the generalizability of the data. What we have from Triton and PLATO is a global, incredible number of sites with a wide array, whereas here in ISAR React 5, it's really mainly 2 countries, Italy and Germany. So the take-home messages, I think, are that while the ISAR React 5, and I think it's important to note that this was a difficult study, unbelievable work by investigators who did great job. I think it's a very important study, and I do think that if this is true with a cheaper drug with Prasugrel, I think we should all be using Prasugrel instead of Ticagrelor. But there are important limitations, and these important issues should be talked about. And really important to kind of think about the current advancements of where we are with devices, drugs, operator expertise. Are the findings from prior landmark randomized clinical trials on P2Y12 still valid? How and to what extent is the timing of drug administration and the use of upstream P2Y12 loading dose impact on the outcomes after PCI? How do we explain the discordance of reducing bleeding without, reducing ischemic events without increasing bleeding events is one that I just do not understand. And then does one P2Y12 inhibitor fit all of the ACS patients? Should we tailor this according to the patient's risk profile? And we need to really, really understand that. And so for me, I would say, instead of saying stick to the guidelines or change your practice, I would say just keep your eye on the patient and really do a great assessment and think about what's best for that patient. What's their adherence rate? Are they going to be able to take a BID dose? Is this going to be a better drug for them with less side effects, et cetera? And based on that, I would just say, let's keep on the patient. Thank you so much for your attention.
Thank you very much, Roxana, for that great talk. So in the last couple of minutes, we'll just take a poll from the panel members. How many of you have switched over to Prasugrel because of the ISAR React 5? Bryan, you are in a big clinical practice. What have you done?
It has made minimal impact on me yet. I'll agree with Roxana. I'll watch I'll watch for the future. I'll keep my eye on the patient, but I'm not ready to sign up yet.
Dr. Palmerini in Italy, you are in a big center.
So I think we need a confirmatory study before changing practice, because as Roxana said very well, there are many limitations of the study, and we cannot buy it without a confirmatory study.
Dr. Mehta in Canada?
Yeah, we have not changed our practice. In fact, Prasugrel actually has been taken off the market in Canada. It's not even available for us to use. We just have Clopidogrel and Ticagrelor now. And that's a relatively recent advance.
Why is that?
It's hard to know. I think there are commercial reasons for that, and the impact of the Prasugrel studies in Canada really didn't resonate, given it's a big country, large geography, and waiting, if the patient has to wait to get to the cath lab, they would be untreated with just aspirin, and so it really didn't take off. So I think commercially it wasn't a success, and the companies that make it just have abandoned it, basically.
Deepak, in the Harvard system?
Well, I can just say about the Brigham, there's other.
Yeah, you have to be careful there.
Exactly. I don't want to step on Dr. Gibson's toes. He gets very sensitive. But at the Brigham, of ADP receptor antagonists, last time I looked, 80% was Ticagrelor for ACS patients. And the remainder was largely Clopidogrel, either because they were at high bleeding risk or for insurance reasons. I will say, though, Prasugrel is now generic, and there have been some third-party payer unpleasantries where they've sort of said no to Ticagrelor and kind of forced our hand to use Prasugrel. But that had nothing to do with SR React 5. That just had to do with cost. But in terms of my own interpretation of SR React 5, I mean, honestly, I think Dr. Mehran's dissection of it was the best I've heard. I don't really have, I guess I will add one thing, just maybe because Dr. Mehta, I can see him here. It struck me as odd that the degree of benefit seen with Prasugrel, an active drug, versus Ticagrelor exceeded the degree of benefit seen back with cure and PCI cure that Dr. Mehta did with Clopidogrel versus a placebo. I mean, it just seems kind of hard to believe that two active drugs have such a huge differential in favor, in this case, of Prasugrel, when even Clopidogrel didn't beat a placebo by that margin. I can't think of any reason other than the open label, introducing some sorts of differences in treatment patterns, or the fact there was one other asymmetry with the randomization. That is, I mean, I guess they were following the label, but there wasn't any Prasugrel pretreatment. There was Ticagrelor pretreatment. That could have influenced further downstream care and delays to care, especially if surgery or something was being entertained. And I guess the only plausible explanation would be that, there was just a ton of Ticagrelor discontinuation, more so than we see in the clinical trials, more so than I see in at least my own practice. And that's why Prasugrel looked better. That is just better adherence. But even then, if it's just better adherence, you'd still expect more bleeding. That is, if everyone's taking the Prasugrel and no one's taking the Ticagrelor because of side effects, okay, you get more efficacy, but you should also get more bleeding. So I don't know, I can't really reconcile the huge efficacy benefit, but no bleeding differential. That just doesn't make sense to me.
And if we are to do a confirmatory trial, it really does need to be blinded, because a BID versus a QD drug, it just is really difficult to, there's a bias against that BID drug no matter what. We're all wanting our patients to remain adherent. And if anyone is planning such a trial, it needs to be a blinded study.
Yeah.
Roxana, can I ask you a quick question? The SR React is actually a comparison between Ticagrelor strategy versus a Prasugrel strategy. And this is because of the evidence that were available at the time when the study was designed. So in which way do you think that this different strategy could have represented a disadvantage for Ticagrelor? And if you had to design a new study now for comparing Ticagrelor versus Prasugrel, how would you do that? How would you do it?
Well, I mean, I think if you look at the randomized clinical trials, so first of all, I can see that pretreatment may be necessary. Dr. Mehta mentioned Canada, big country. Sometimes people have to be transferred into the academic center. You're going to treat them with something, and you're going to give them, dual antiplatelet therapy, Clopidogrel, Ticagrelor. But at least, in situations where moving to the cath lab occurs quickly, if one looks at the data, randomized data, pretreatment has not been shown to be efficacious, and in some cases raises bleeding. If you look at, trials like ACOAST, granted that was with Prasugrel, pre-treatment didn't work. The trial was terminated for excess bleeding by the Data Safety Monitoring Board with lack of efficacy. So while pre-treatment is theoretically sound and trials that have employed pre-treatment, such as CURE and PLATO, looked good, when one has actually studied the strategy, not the drug, but the strategy, it to date remains unproven. So, again, I think mixing that into a trial of Ticagrelor versus Prasugrel, some patients are pre-treated, some aren't, just makes it, a bit messier to interpret. But having said that, I don't mean to criticize the investigators. I think the investigators did a good job trying to answer a question, that industry wasn't going to answer, right? I mean, the Prasugrel companies and the Ticagrelor companies, no one was going to fund this trial. And to do this trial, like Dr. Mehran said, you need, 20,000 patients, more than 20,000, not, 2 or 3 or 4,000. So that's the fundamental problem. To answer a question like this would require deep pockets. The investigators, did what they could in their budget. It took them several years to get the trial done, and they got it done. But so it's not a critique of them. But having said that, at the end of the day, I don't find the data actionable.
Yeah, just to go back to something Roxana said earlier, she said the guidelines committee was critical of what we did in the Triton study with respect to Prasugrel and not preloading. When we did the Triton trial, there was no real data supporting preloading. All we had was Credo, which did not show a benefit. I agree with Deepak. When I look at the data, get rid of all the non-randomized data. Look just at the randomized data. You do not see a benefit in efficacy. You see more bleeding. So I'm not sure that was a reasonable concern on the part of the guidelines committee, to be honest. I do think the big problem here, all of you made the right points. Obviously, I led the Prasugrel trial, so I was kind of excited when I saw the top line results saying, I told you guys. But when you look at it more carefully, I think Roxana did a nice job of putting out the limitations out there. And I'm really concerned about the unblinded nature of the trial. But I also agree. I mean, we really have to applaud the efforts of these investigators for doing a trial that no industry sponsor was ever going to do. But you got to blind. I think it really shows the importance of blinding.
Well, since you got a chance to rebut that point, Dr. Mehran, I've also got to stick up for Champion, where, likewise, what we did there with Canglor, yeah, I agree, we could have given Clopidogrel earlier and pre-treated and so forth. But the reality is there really isn't any data supporting pre-treatment from a randomized perspective. I'm not saying that Clopidogrel looked great with pre-treatment, PLATO, Ticagrelor looked great, but those weren't trials of strategy of pre-treatment versus no pre-treatment. And there's just no data that, no randomized data that supports it. So that's why Triton, for that matter, even Champion, Phoenix were designed in the way they were, because there just wasn't a sort of mandate to pre-treat, despite the guidelines endorsing them. The randomized clinical trial data just doesn't support it.
Yeah, I guess I would just, my comment on that is just, it's probably a matter of time that people have to wait to have something done, right? There has to be a finite period of time when you're going to start to see a benefit of pre-treatment. And if you take it to the extreme, it's a conservative strategy. Somebody never goes to the cath lab. We know there's a benefit of a P2Y12 inhibitor. So the issue is not, it's always framed as pre-treatment or no pre-treatment. That's not how the question should be framed. The question is an issue of timing and how long it takes people to get to the cath lab. If there are a few days, if it's a Friday and the patient's not going to be in the cath lab till Monday, it makes sense to pre-treat. But if it's a Monday morning and the patient's going at noon on Monday, then there probably is very little benefit of a pre-treatment strategy. So the problem with the whole issue is that it's been improperly framed, right? It's not being framed from a patient point of view. It's being framed from, there are other competing issues. And I think every time I see a presentation on this, I'm saying, it's a good thing you didn't have your MI in Northern Manitoba, because believe me, you would be begging to be pre-treated before you can get into a cath lab. So I think the question is improperly stated, and I cringe when I see these debates of pre-treatment versus no pre-treatment. They should really be abandoned, and we should start taking a patient-centered approach.
Oh, sure. No, I agree. But I started my comments, I prefaced them by saying, as you refer to, if someone's in Canada getting transferred into an academic center from a more rural place, yeah, of course, I'd pre-treat. But, you know, I think just looking at the most recent sort of registry data, you know, most patients in the US that are coming in now with their NSTEMI are being treated within 24 hours. I know at my own center, you know, we're doing NSTEMIs on the weekends now. So I think that if there is going to be a delay of more than 24 hours, certainly if you're parking them for the weekend, pre-treatment makes sense. But I think if the time to cath lab is relatively quick, you know, as it is with many centers where it's a de novo presentation, the patient's presenting to that center's ER, they have a cath lab and PCI capability, you know, in that sort of patient, I think there's a bleeding hazard from pre-treatment, a potential delay in surgery if it's needed, cardiac surgery, and no proven benefit.
Yeah, so that's the right way. I think that's really how to frame the whole pre-treatment argument. It's an issue of timing. And then in the issue for guideline committees, I think, is how do you make a recommendation when you don't know the specifics of a center? And how do you manage as a physician when you sometimes don't, it's out of your control, when you don't know when the patient is actually going to arrive in the cath lab, you know, and you know, these are all really important issues, and patients get caught in the middle of them. Because people want to take a side one way or another, and it's not that straightforward. So,
well, people often forget about, it's not randomized, but it's interesting kind of retrospective data from CREDO looking at the sweet spot, which turned out to be 19 hours. If there's a 19-hour more delay, then pre-treatment was of help. That seems like a nice cut point, about a day, but I agree with your approach, Shamir.
Thank you, everyone. Bryan, do you have any final take-home message in a next 30 seconds?
I would have to say that for 10 years we've been doing this thing, and I would have thought we'd have come up with every single answer to antiplatelet therapy. And here we are 10 years later, and I can't wait for next year's, because we've asked questions here that hopefully will be answered in the next year, and more will be generated. This was fantastic.
Thank you very much, all the faculty members, for taking such a valuable time on a Sunday afternoon to be with us. I want to thank all the attendees here in US, and also all the attendees on other way of listening to this webinar in Venezuela, India, Italy, Greece, Mexico, Malaysia, Paraguay, Bangladesh, Egypt, Namibia, Vietnam, Tunisia, Pakistan, Kuwait, Austria, South Africa, Argentina, and Ecuador. I know some of these territories are at an odd time in the day, so thanks for sticking with us. Thank you, everyone. Have a wonderful evening of this Sunday, and have a great week ahead. Thanks so much for your participation. Have a wonderful night.
thanks, everyone.
Bye.
Okay, bye. Take care, everyone. Stay safe.
Thank you.